Good morning, everybody. My name is Dr. Calvin Yifenli, and today I'm going to talk about PANDAS syndrome. So I did my MBBS in Jiangsu University School of Medicine, and in Asia, in Asian countries, usually we have 1 year of internship where we go to different departments and different specialties to rotate, and then we graduate. So while I was doing my pediatrics rotation in SVP, Postgraduate Institute of Pediatrics, which is one of the premier institutions of pediatrics in India, I came across a very interesting case. So this is a case study that I saw back in India. So a 6-year-old schoolboy comes into the clinic due to refusal to eat. We check his vital signs and they turn out to be normal. Now his parents, they report that in the past 3 weeks, there was a sudden abrupt declines in cognitive functioning, concentration, ability to focus, loss of math skills, onset of dysgraphia, and difficulty with social cues, decreased processing speed, word selection problems, anxiety, fatigue, nighttime awakening, chills, joints, and muscle pain. He also has moodiness, general and separation anxiety, and panic attacks. So when his parents told us about these symptoms, it just looked like a hodgepodge of neurological and psychiatric problems. Now, he used to be a straight A student, and he never had difficulty with his studies. And the past 3 weeks, it was just a very acute onset of his problems. Like he went from straight A's to D's. He would have trouble in school, trouble learning new materials. And he's 6 years old, so he's not supposed to have separation anxiety and generalized anxiety, but he did. So in addition to that, he also experienced obsessions and compulsions. He also became aggressive, which was out of character according to his parents. So initially, when we heard about this boy, my senior resident, he was intrigued by the constellation of symptoms that he saw, and he called me. So our initial impression was that maybe he has some kind of a psychiatric disorder. So upon further questioning, we came to know that 6 months ago, the patient went on a family vacation to a tick endemic area in India. So he also had 3 episodes of streptococcal pharyngitis infection occurring during the 6 months interval. Now, his mother denied that she didn't see any rashes in the patient's body. Know how to proceed forward, so we ordered a battery of tests. So the differential diagnosis that we had in mind was, first, because he went to a tick endemic area, so it could have been a tick-borne encephalitis, like Lyme's disease. We know that in the late stages of Lyme disease, it starts to affect the cardiac system and the central nervous system. So you have tick-borne encephalitis and you have other problems. The second thing, because he had a history of strep pharyngitis within the 6 months, so we thought it could be PANDAS syndrome. The third differential diagnosis was PANS. So PANS syndrome is caused by different organism, but it has the same, almost the same symptoms as the PANDAS syndrome. Now, because of its acute onset within 3 months, because of his acute onset of cognitive decline, it was also possible he could have prion disease. And the fifth one was viral encephalitis, like Japanese encephalitis virus, because in India, due to poor sanitation and poor hygiene, it's a breeding ground for mosquitoes. And these viruses, like the Japanese encephalitis, the West Nile virus, Eastern equine, Western equine viruses, they are all carried by the mosquitoes, and it could affect the brain and cause personality changes, cognitive changes, etc., etc. So we did some investigations. His EEG was normal because we wanted to know if he had any abnormal focus and abnormal brain waves. His MRI was normal because we wanted to rule out any mass lesions that could potentially cause a change in the personality, like a lesion in the frontal lobe or frontal release signs, So we also did blood work, and it revealed increased ESR and CRP levels. So this indicated some kind of an inflammation in his body and maybe potentially some kind of infection. We did a Lyme serology and it was negative, but his anti-DNase antibody and anti-ASO antibody titer was positive. So this indicated that, okay, he had some kind of an autoimmune disease associated with the streptococcal pharyngitis infection that he had a few months back. We did a CSF. The CSF was grossly normal with normal glucose levels, but there was increased leukocytosis and proteins indicating some kind of an inflammatory reaction in the brain. So after all the results, we came to a diagnosis. So given the history and laboratory results, the diagnosis of PANDAS was made. So now the question arises, what is PANDAS syndrome? So the full form of PANDAS syndrome is pediatric autoimmune neuropsychiatric disease associated with streptococcal infection. So it is fascinating that a patient could have both neurological as well as psychiatric symptoms together. So PANDAS syndrome is a group of symptoms such as tics and obsessive compulsive behavior. And it's thought to affect certain children who've had strep infections. Now, it doesn't affect every children, but some of them, they do have an autoimmune reaction to streptococcal infections. Now, mostly it is thought to occur with group A streptococcus infection like streptococcus pyogenes. Now, group A streptococcus is also notorious for causing other autoimmune reactions like acute rheumatic fever, where you have mitral stenosis. It could also affect your brain because your body starts to produce autoantibodies against your nervous system. As well as if you have a family history of autoimmune diseases or rheumatic fever, you are more prone to develop PANDAS syndrome. Now, why is it important to differentiate between PANDAS and PANS? Now, PANDAS and PANS, they have almost the same constellation of syndromes. PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. So people think, okay, maybe PANDAS is a type of PANS. They have similar symptoms that come on suddenly. It has an insidious onset. But PANDAS is specifically related to streptococcal infection, whereas PANS is thought to result from other infections such as Lyme's disease or influenza. Now, given the patient's history of going to a tick endemic area, so it was also logical that he could have a PANS caused by Lyme disease. So what is the difference between PANS and PANDAS? As you can see here in the middle, they have common symptoms like acute onset of OCD, tics, and or restrictive eating behaviors. The difference is it can occur in children, teens, and adults. PANDAS is typically occurs between 3 years old and puberty, so it doesn't occur in adults. PANS can be triggered by infectious and non-infectious causes. PANDAS is specifically triggered by group A streptococcal infection. So what are the signs and symptoms? So as the name indicates, it's a neuropsychiatric disorder. So it has a wide variety, like it varies from child to child, and it can involve a combination of psychological and neurological conditions. It has an insidious onset, it goes away and returns like relapsing remitting type. The psychological symptoms that are most commonly observed in these patients are anxiety or depression, bedwetting, psychomotor agitation, anorexia, obsessive compulsive like disorder, vocal and motor tics. The neurological symptoms include reduced motor skills, difficulty in concentrating, coordination problems, phono and photophobia, and as we have seen in our patient in the previous case study, that he also had dysgraphia and he had trouble concentrating. So these are the most common signs and symptoms that are associated with this condition. What is the etiology and pathophysiology? So as I said before, the etiology is infection with group A streptococcus, especially the Streptococcus pyogenes. Now, we don't exactly understand the mechanism behind it. But most commonly accepted mechanism involves the following. So you have an acute tonsillitis or pharyngitis caused by group A streptococcus. And the patients think that, well, it's just a sore throat, it would go away. So they don't take antibiotic treatment, they take home remedies like hot tea, chamomile tea, lozenges, all these. So what happens is, if the infection is not eliminated, antibodies develop against streptococcal M protein. Now, streptococcal M protein is notorious for causing this, for confusing the immune system, which causes cross-reactivity of antibodies with nerve and myocardial proteins. We call it molecular mimicry. This results in type 2 hypersensitivity reaction, which means that your antibodies are specifically targeting certain antigens in your body. And this causes inflammation in basal ganglia functions. So basal ganglia functions, when they are targeted and they are affected, it causes a change in a person's personality, and it causes a lot of psychiatric symptoms that are unique to PANDAS syndrome. So this mechanism is also very similar to the mechanism of how group A streptococcus causes acute rheumatic fever. As we all know, acute rheumatic fever, it also has a CNS component. If we could recall the Jones criteria: migratory polyarthritis, cardiac inflammation, lymphadenopathy, erythema marginatum, and sydenham chorea. So the sydenham chorea component is a neurological manifestation of group A streptococcal induced rheumatic fever. So here in this picture, we could see the stages of how this this PANDAS syndrome is manifested. So we have exposure to infection, immune response is launched by our body. The antibodies, you can see here, it gets confused because the M protein in streptococcal organisms, they are similar to some of the proteins, some of the antigens found in our own body. So the antibodies attack the basal ganglia, and you have sudden onset of OCD, tics, anxiety, etc. So you have motor tics, anxiety, handwriting deteriorations, and restricted eating. You also have irritability, sleep disturbances, and mood swings. So what is the diagnostic criteria? So it is most commonly a clinical diagnosis. Like you have to establish a temporal relation of the streptococcal infection and the subsequent development of these symptoms. So we don't have a specific lab test that would rule in this diagnosis. So the way we diagnose this is if we see presence of OCD and or a tic disorder, and if it has a onset during childhood, it has an insidious and acute onset, and it is episodic in nature. It comes and it goes. And as I've said, there should be a temporal association with streptococcal infection. So the infection should come first, and then after a few weeks to months, you have the symptoms. Also, neurological abnormalities during episodes like motor hyperactivity, coriform movements of fingers or toes. So what's the treatment? The treatment plan is very similar to the treatment of acute rheumatic fever. So we use antibiotics to eradicate the organism most responsible for the condition, which is the group A streptococcus. We usually use penicillin, amoxicillin clavulanate, beta-lactamase antibiotics for a few years to eradicate the organism. Secondly, for the psychiatric aspect of the symptoms, we use cognitive behavioral therapy and pharmacological therapy for OCD and tic disorders. Usually, SSRIs help with the OCD, and antipsychotics help with tic disorders. And we use a second generation antipsychotic because the first generation causes extrapyramidal symptoms. And then we have the AHA guidelines. So the guidelines state that it is not recommended to do a routine laboratory testing for group A streptococcus to diagnose the long-term anti-streptococcal prophylaxis to prevent, or immunoregulatory therapy such as IVIG or plasmapheresis to treat exacerbations of this disorder. So it's not recommended to do routine laboratory testing or to give long-term prophylaxis treatment for anti-streptococcal infection and IVIG and plasmapheresis to treat the exacerbations of this disorder. So prevention is better than cure. So the ways to prevent it is to prevent getting infected with group A streptococcus in the first place by encouraging good hygiene. So this could be achieved by covering their noses and mouth with a tissue or the elbow when they cough or sneeze, not sharing food, drinks, or personal items such as toothbrushes, and washing their hands frequently and using hand sanitizer whenever possible. Now, the prognosis is usually good. Many of the children that are treated with antibiotics and treated with cognitive behavioral therapy, they see remission in symptoms. So focusing on cognitive behavioral therapy for the behavioral problems and habit reversal training for tics help decrease the frequency of symptoms and provides children with the coping skills they need to succeed. So that is the presentation about the PANS and the PANDAS syndrome. If there are any questions regarding the presentation, I'm here to answer.
Okay.